Hi, my name is Afshin Heidari. I'm from UIC MGH Residency Program. I'm from Advocate in the Masonic Medical Center. We don't have any financial relationship or conflict of interest to disclose. Today I'm going to talk about the surgical approaches for treatment of esophageal cancer, and the bulk of the talk is going to be toward the trends toward using and utilizing minimally invasive techniques in doing the esophagectomy. As we all know, esophageal cancer is one of the common GI cancers, and from a surgical standpoint, it's very famous for challenging approaches to do the esophagectomy. We have three famous surgery approaches. Ivor-Lewis, which surgeons do two different incisions, one in the abdominal incision and one right thoracic incision, and usually the anastomosis is intrathoracic. And in a three-hole technique, an additional cervical incision will be added to the procedure, and a neck anastomosis will be performed. And in transhiatal approach, one abdominal incision and one neck incision, and the mediastinal dissection is carried bluntly. All these procedures are challenging in terms of big incisions and vigorous retractions, and especially due to anatomical limitations and the location of the diaphragm. Also, the laparoscopic approach have been explained. Some surgeons do the abdominal and the mediastinal dissection through laparoscope, and then they carry the rest through open approach, and some do the laparoscopic or VATS surgery for the mediastinal dissection, and then they carry the rest as open procedure, and some people do it as a complete package of minimally invasive technique. And robotic assisted approach has been explained as well. There are some benefits that has been explained in literature for minimally invasive techniques. Patients will lose blood loss, less blood loss during the surgery, and they will benefit from shorter cavity exposure through the surgery, and they will be decreased in collateral injuries due to less extensive surgical incisions. In short-term benefit, we can mention the shorter recovery after the surgery, less post-op pain due to smaller incision and less retractions, and few complications, especially atelectasis and respiratory standpoint, and ileus from GI standpoint. From long-term benefit standpoint, there is no study showing that there is a significant long-term survival difference between those two groups. And those studies who are in benefit of 1 year quality of life benefit are all biased by small samples. And we think that there must be a better prognosis by using the minimally invasive technique, which I will explain later. Considering the advantage of minimally invasive techniques and hardship of open surgeries, we hypothesize that maybe there is a national trend toward using minimally invasive techniques to perform the esophagectomies. And to evaluate this hypothesis, we compare those two groups. We used the National Inpatient Sample Database, and we used ICD-9 codes for esophageal and G-junction cancers. And we, for the total esophagectomy and Ivor-Lewis, we used ICD procedure codes. And we use supplementary codes for using or not using the laparoscopy robotic approach during the surgery. And at the end, we use the SAS Enterprise 6 to compare those groups and data. As you see here, total number of 2,453 cases has been performed, esophagectomies due to cancer has been performed. 1,398 procedures were total esophagectomy, and out of them 143, which 10.22% was performed minimally invasively. And in Ivor-Lewis group, there was 1,055 patients who underwent this procedure, and 9.76% of them used the minimally invasive techniques. As we compare through the years, you can see here that In Ivor-Lewis group, there is more variation through the years by using the minimally invasive techniques, although the numbers will show that maybe the number at 2014 is more, but the trend is up and down. But in total esophagectomy group, almost there is a trend toward using the minimally invasive techniques. There was some additional outcome that we were able to obtain from our study. Average length of stay in minimally invasive Ivor-Lewis group were 15 versus 18.1 in open surgeries, which was significantly statistically significant. And but in total esophagectomy group, the length of stay was not significantly different. Mortality rate in open approaches were 5% and near to 0 in laparoscopic cases, which was significant. And we were also able to measure the total charges for minimally invasive esophagectomies, which surprisingly, it was when we adjusted with inflation, it was less in 2014 compared to 2010. As a conclusion, despite that the numbers showed that the number of minimally invasive techniques are increasing through the years, we were not able to statistically prove that there is the national trend toward using minimally invasive techniques for esophagectomy. Although and we were able to prove that there is a significant change in mortality, difference in mortality in open and laparoscopic groups, which was significant in our study. And we were able to show that if you saw those graphs, almost number-wise, the number of the minimally invasive cases are increasing, but they are not significant statistically. So as a discussion, I can tell that although minimally invasive techniques are very growing these days and they are very famous and in some surgeries they are a standard of care, but we were not able, we think that surgeons are more cautious and reluctant in doing minimally invasive techniques in esophagectomy. And that may be due to different reasons, maybe due to not being familiar with these techniques, or maybe due to lack of significant studies showing the benefit through the years for minimally invasive techniques compared to the open surgeries. Thank you for having the opportunity to present.